We are rolling.
Okay, in this lecture we're going to talk about the main test that is used to examine the peripheral nervous system. And that test, of course, is the EMG, otherwise known as electromyography. Technically speaking, EMG refers to the needle part of the examination, but since most people, when they use the term EMG, mean the whole test, that terminology is fine. Strictly speaking, the test consists of two parts, the nerve conduction study and the needle electrode examination. So let's talk about the nerve conduction study first of all. And one thing that's important to remember when we think about EMG is that this is a test of the peripheral nervous system. All right, and so what are we checking here? We're checking things from the anterior horn cell through the nerve roots, plexus, peripheral nerve, and we also get information about the neuromuscular junction and muscle. So in other words, if you're dealing with a brain stem, or a spinal cord pathology, this is not the correct test. All right, we're just evaluating the peripheral nervous system. All right, so let's talk about the nerve conduction study first of all. And when we think about the nerve conduction study, there are two parts. We check motor nerves and we check sensory nerves. Okay, and we evaluate similar things on this test. First of all, let's just say this is the ulnar nerve. Okay, and we'll draw this out in a subsequent lecture, but the ulnar nerve, recall, comes from the lower trunk of the brachial plexus and from the C8 and some T1 anterior horn cells and nerve root. And so let's say we're evaluating the ulnar nerve, and let's start with the motor function. And so what we'll do typically is we'll come along and we'll stimulate the ulnar nerve at various points. We might stimulate the nerve above the elbow, or we could even stimulate it in the axilla, below the elbow, and at the wrist. Okay? And our goal here in giving this electrical stimulation of the nerve is to what's called do supramaximal stimulation. And what this means is we stimulate 100% of the nerve fibers to depolarize. Okay, and so that action potential travels down the nerve, okay, stimulates release of acetylcholine, and then we activate muscle fibers. Okay, so again, if we're stimulating the ulnar nerve, we might record a typical muscle to record over would be abductor digiti minimi, or we might record another hand muscle supplied by the ulnar nerve, the first dorsal interosseous. All right, so we stimulate the nerve. Okay, we get depolarization of muscle fibers. You can see the hand twitch when we stimulate the nerve. And we put a recording electrode, we'll just put an R here, over the muscle that we want to assess. Okay, and so what we're checking for here is several things. First of all, we check the amplitude of the response. So if we stimulate here, we wait until the impulse gets down to the muscle, and we get a waveform. And we stimulate maybe below the elbow, we get a waveform, and at the wrist, we get a waveform. And in a normal individual, these should be identical. Okay? Now, they're occurring at different times because, of course, this is further away from the muscle, but the amplitude should be the same. And this amplitude is referred to as the CMAP, the compound muscle action potential. Okay, this is the most important information that we get from the motor nerves, because the CMAP, in other words, this amplitude, reflects the health of the nerve and neuromuscular junction, and it also reflects the health of the muscle as well, because, of course, you have to be able to, what actually generates this amplitude is depolarization of muscle fibers. So in other words, the CMAP, compound muscle action potential, tells us about the health of the peripheral nervous system, neuromuscular junction, and muscle. And how do we know what's normal? Well, thousands of patients, normal patients, have had this test done. And so we have numbers, which you don't need to know about, but we measure this, or the computer does. And we know how high that should be, and we can tell if it's normal or abnormal. And those numbers change with age. And again, you don't need to know about that. I just want you to know the basic principle of how the test works. All right, so we measure the CMAP. The other thing we'll measure is what's known as the distal latency. And the distal latency refers to the time it takes to get from the most distal stimulation to the muscle. All right, so I'll just put DL here, distal latency. And there are certain times when a distal latency is very important. If we're checking for carpal tunnel, for example, and we're stimulating at the wrist and recording over a thumb muscle, we know how long it should normally take. Okay, and if someone has carpal tunnel, it's going to take longer for that impulse to travel through the wrist. Okay, so we measure CMAP, we measure distal latency, and the other thing we do is to measure conduction velocity. Okay, because we're measuring, and we actually get out a little tape measure, and we measure precisely to the point above the elbow, below the elbow, to the wrist. Okay, and so we calculate conduction velocity, which is meters per second. And a good rule of thumb is in the upper extremity, nerves conduct about 50 meters per second. Okay, so those are the three main things: CMAP, distal latency, and conduction velocity that we assess with motor nerves. Okay, and in just a minute I'll explain what abnormal nerves look like. Now, sensory nerves, we measure very similar information, but of course the sensory nerve here, if we just follow this from the dorsal root ganglion, sensory nerves don't activate muscles. They go out to supply skin with sensation. All right, so when we're stimulating sensory nerves, typically we'll just do this in one place. Okay, these are smaller nerves, somewhat more difficult to get information about. But now we're putting the recording electrode over the skin. Okay, so for example, if we're stimulating the ulnar nerve, of course we're going to still stimulate the ulnar nerve, but now we typically put a ring electrode around the 5th digit, for example. Okay, so as that electrical impulse travels along the nerve, we can pick up that current as it passes along the ulnar sensory nerve. Now, kind of the contrast here to CMAP, remember the amplitude for the motor nerves. For sensory nerves, we refer to that as the SNAP, and SNAP, and that stands for the sensory nerve action potential. All right, and what is the sensory nerve action potential? Well, it reflects the health of the nerve. Again, we're stimulating 100% of the sensory nerve fibers here, and as that impulse passes along the skin, we record that, and it has a waveform, looks similar to the motor waveform here, but it's much smaller. And again, we have normal values, so we know how big it should be. All right, so the SNAP tells us about the health of the sensory nerves. Tells us nothing, notice, about the neuromuscular junction, tells us nothing about the muscle, tells us nothing about the motor nerve, tells us about the health of the sensory nerve. All right, and so by combining information here about motor and sensory nerves, we really get a lot of information. Now, we also measure a distal latency, okay, just as we do for motor nerves. So again, for carpal tunnel syndrome, we stimulate the nerve, this time maybe recording over a sensory part of the nerve, like over the thumb or over the index finger. We know how long it should take to get from point A to point B, and if it takes longer, then is suggestive that we're dealing with carpal tunnel syndrome. Okay, so just with that very basic information, let's go through and give some examples of some pathology and what you would see on nerve conduction study. All right, now let's say, let's start with an easy one. Let's say the patient has diabetes and they have a peripheral neuropathy. All right, and so what happens is we have a degeneration, typically starts of the sensory nerve fibers, but eventually there's some motor involvement. Okay, and to make it easy, let's say that we've lost 50% of our nerve fibers, both motor and sensory. Okay, so we've got a drop of about 50%. All right, what are you going to see when you do motor nerve conduction studies? Well, if this is the normal, okay, and remember that the more proximal part of the nerve will be normal, okay, because this slowly dies back. But if we are stimulating a distal muscle in the hand or foot, and we've lost 50% of that, then of course wherever we stimulate proximal to that, the size will be about half. Okay? And that would be for both the CMAP and also for the SNAP. Now, the SNAPs drop out much sooner in most peripheral neuropathies, but that's kind of a fine point. The point is that when we have an axonal process, like a peripheral neuropathy, that is going to cause a reduction in our CMAP and in our SNAP. It'll be, in this case, about half of the normal size. Okay, so that would be very suggestive that we're dealing with some sort of an axonal process. Now, something that's a little bit more tricky. Now, let's say that in this case we put the lesion up here in the plexus. Okay, and let's use our example again of maybe a 50% process. We've destroyed 50% of the axons in this part of the plexus. Okay, what are we going to see now when we stimulate nerves distal to that? Okay, and the key thing for figuring this out is to realize that when you damage a nerve, remember there's Wallerian degeneration. Okay, and so if you destroy 50% of the nerve fibers here, well, those 50% are going to degenerate all the way down to the distal part of the nerve. Okay, and so the point is whether you destroy 50% of the nerves here or here, it's going to look exactly the same on our nerve conduction study. We're still going to get a response that is 50% of what normal is. All right, and so the point here is it's often very, very difficult, just based on nerve conduction studies alone, to say where the problem is. Okay, this is frequently why we need the needle examination to figure this out. All right, but again, the main take-home point here is when we think about the CMAP and the SNAP, if those are reduced, it tells you this is some sort of an axonal process. The axons are being destroyed, and you may not be able to figure out whether it's proximal or distal. We need to do other parts of the test for that. Okay, so that's for an axonal process. What if we have a demyelinating condition? Okay, remember myelin is important for speed of conduction. Okay, so if we have a demyelinating condition like Guillain-Barré syndrome or some sort of a demyelinating neuropathy, the main thing we're going to see here is not just a diffuse loss of amplitude, either CMAP or SNAP. Now we're going to see a slowed conduction velocity. So instead of maybe conducting at 50 meters per second, it might conduct at 30 meters per second. Or if we're dealing with something like Charcot-Marie tooth, a severe hereditary demyelinating neuropathy, it might be 10 meters per second. Okay, so a slowed conduction velocity would tell you you're dealing with a demyelinating condition. Okay, but even more important is that you understand what happens with conduction block. And conduction block refers to a focal loss of myelin. Okay, and this happens in Guillain-Barré syndrome. That would be a great example where patients just pick off individual nerves in specific parts of individual nerves. Okay, let's say we have a patient here that has Guillain-Barré syndrome. And again, let's stick with this being the ulnar nerve. And let's say that in this patient, we have a focal loss of myelin right here. Okay, and we'll use 50% for everything. Let's say we've lost 50% of the myelin right here at the elbow. Okay, so this is stimulating at the wrist, stimulating below the elbow, stimulating above the elbow. Okay, what are we going to see if we lose 50% of the myelin right here at the elbow? Okay, and again, this is what it normally should look like. And now let's try to think through here. What's going to happen if we stimulate at these three locations? Okay, what's going to happen if we stimulate at the wrist? Well, the key here is the destruction occurred to the myelin, not the axon. So we don't get Wallerian degeneration. In other words, the nerve distal to this is perfectly normal. Okay, the patient is weak because they can't send the action potential, from the brain to the anterior horn cell through this point, but the nerve distal to this is perfectly normal. Okay, so in this patient, we stimulate at the wrist, normal. We stimulate below the elbow, normal. Okay, but when we stimulate proximal to the area of conduction block, okay, and again here we've got a 50% loss, well, you get a 50% drop. Okay, and this is known as a conduction block. Okay, and so if you order an EMG and the report comes back, oh, we found conduction blocks, you know that that means that this is a demyelinating condition. Okay, so Guillain-Barré can do that. We can have conduction block at the wrist from carpal tunnel syndrome. Okay, but conduction block is very helpful because it tells you exactly where the problem is, and it tells you that it's a focal loss of demyelination. And that's why patients with Guillain-Barré do so well. Okay, because if the axon is not involved, then these nerves remyelinate. Patients get stronger again. They recover. All right. Now let's talk a little bit about the needle electrode examination. Now sometimes we don't need to do this test. If someone is just referred for carpal tunnel syndrome, we'll just do nerve conduction studies. Not everyone needs to have a needle electrode examination. But this part of the test involves, of course, putting a small needle that has a recording device into individual muscles. Okay? And so let's just pretend here we have a cross-section of a muscle. And remember that in each muscle there are individual motor units. Okay, so let's just draw, maybe let's draw 3 different motor units to make it real simple. Okay, so let's say we have the green as one motor unit, and we'll have maybe red here as another motor unit. Okay, and that's how the motor units are displayed in a muscle. They're scattered out. Okay, so we have 3 motor units here in this example. And remember what a motor unit is. It's the single anterior horn cell and the single projection from that anterior horn cell all the way to these individual muscle fibers. Okay, so let's stick maybe with an ulnar muscle, and let's say we put a needle in the abductor digiti minimi muscle. Okay, and so this reflects the abductor digiti minimi. And so you put a needle in the muscle, okay, and you do a couple of things. First thing you do is you listen, typically. And we used to use an oscilloscope for this, and now, of course, all this is done on a laptop. And when you advance the needle, you can hear the sound, the electrical representation of all of these individual muscle fibers. It makes a sound. But once you have the needle in and the hand is relaxed, in this case, it should be perfectly quiet. You shouldn't hear anything. All right, so 2 things you need to know about, and there are lots of things that an EMGer would look for, but 2 things I'd like you to know to listen for are fasciculations and fibrillations. Okay, you need to know the difference. A fibrillation refers to a single muscle fiber that is dying, essentially. So let's say in this case we've advanced the needle, and this muscle fiber is degenerating. And so we're dealing with this motor unit, okay? And as this muscle fiber degenerates, it sends out a little signal. It's a very regular signal. It sounds like a pop, pop, pop across the screen, and you can actually visualize that. Okay, so a fibrillation suggests you're dealing with a lower motor neuron problem. Okay, and that could be anywhere from the anterior horn cell through the peripheral nerve. Okay, but fibrillations generally indicate you've got an active, ongoing destruction of the lower motor neurons. Okay, it's a very significant find. It tells you there's active disease. All right, a fasciculation, on the other hand, is a discharge not of a single muscle fiber, but of an entire motor unit. All right, so a fasciculation would be a discharge of all of these red muscle fibers. Okay, now remember, fasciculations can be normal and abnormal. Fasciculations in disease are typically part of anterior horn cell disease, like ALS, Lou Gehrig's disease. All right, and so when we see a lot of fasciculations on EMG, those sorts of conditions come to mind. All right, but remember, normal people have fasciculations. Okay, and so sometimes we'll see this in the lab just in a normal person. You know, the eyelid twitch that we all get occasionally. That's a fasciculation. That's just a normal process. Okay, so we listen for fasciculations and fibrillations. Now, the other thing that we do is activate the muscle. Okay, so if we have the needle and abductor digiti minimi, we'll just ask the patient, hey, spread your hand apart a little bit. Okay, and initially we'll ask the patient just to do it a little bit, and then we'll have them progressively give more resistance. Okay, and this is what happens here. Let's take a normal example. So someone is activating the muscle, and what happens is we'll see maybe this motor unit begin to discharge. And then as the patient activates a little bit more, we see another motor unit tick across the screen. And then finally, as they give full effort, in this case, we see the whole computer screen fills up with these motor units. All right, this is what we would see in a normal individual. Okay, what do we see when there's pathology? Let's say that in this patient, let's just say that maybe they've lost a third of their axons. So again, it could be an anterior horn cell disease, it could be a peripheral neuropathy, but in this case, let's just say we've knocked out this motor unit from any sort of a lower motor neuron condition. Okay, so notice what's going to happen. These two remaining motor units are desperately going to try to resupply these muscle fibers. And they do that by sending out collateral sprouts. Okay, and so that's going to happen here for both of these two motor units. And so many of them will be resupplied. Okay, perhaps many of them won't. But in this case, let's say that these two remaining motor units were successfully able to resupply that entire muscle. Now we come along, we put a needle in the patient's hand muscle. How is this going to look different? Well, obviously we're not going to have, in this case, the black motor unit potential. That's what this is called, a motor unit potential. Now we're only going to have two, but notice, since we only have two motor units, but they're now of a much bigger size. Okay, each motor unit now consists of more individual muscle fibers. All right, so in a neurogenic condition, we put a needle in the muscle, we have the patient activate the muscle. What we're going to see now are very large motor units, and there will be fewer of them. Okay, and so red and green here. So large or giant motor unit potentials, and again, most of you won't be doing these tests, but you'll get these reports back. So if the EMGer is describing very large motor unit potentials, what does that tell you? Should tell you there is a neurogenic condition going on. And frequently this goes along with a chronic, long-standing condition because it's taken some time to resupply these muscle fibers. Okay, so fibrillations tells you there's an active muscle breakdown. When we see these large motor units, it tells you this is a chronic process. Now, that's if it's neurogenic. What if we have a muscle disease? What if the patient has Duchenne's muscular dystrophy or an inflammatory myopathy? Well, let's go back here. In fact, let me just take this back to the situation we had earlier here where we have three normal motor units. Okay? In a muscle disease, we're not going to knock out a whole motor unit. Okay? That only happens when we're dealing with a lower motor neuron condition. In a muscle disease, there's just going to be a random dropout of individual muscle fibers. So some of them will just disappear. Okay? And so in a muscle disease where we come in, we put a needle in the muscle, we have the patient activate the muscle. Okay, we're still going to have three motor units. Okay, but notice since there are fewer muscle fibers contributing to each motor unit, they're going to be very small. Okay, and so we'll see three small motor units on the screen. All right, so small motor units, you're dealing with a muscle disease. Large motor unit potentials, you're dealing with a neurogenic lower motor neuron condition. Right? So when we put the nerve conduction study together with the needle electrode examination, we're really very accurate in describing, is this a nerve, neuromuscular junction, or a muscle disease? And very often we can be quite precise in even telling you exactly where the problem is. Now let me just make a couple last points about EMG and ordering EMGs on patients. EMG is generally very successful if the patient has weakness. Okay, so if it's a lower motor neuron problem and the arm or leg is weak, your yield from that test is going to be very, very high. If, on the other hand, the patient has, let's say, numb toes, and all you find on examination is a little loss of pinprick, for example, down in the toes, a small fiber sensory problem like that, the yield is pretty low. All right, and so we're much more useful if there's weakness. Also, in EMG, it's a rather uncomfortable test. I mean, we're shocking nerves, we're putting needles in muscles. And so if the patient has diabetes, for example, and they look like they have peripheral neuropathy clinically, there's no need to do an EMG. I mean, you've proven clinically the patient has neuropathy. There really isn't a need to do an EMG just to confirm what you already know. The other thing is, let's say we have a patient, maybe an 85-year-old man that has neck pain and some numbness down the arm. Okay, but he has a normal exam. Maybe he has a lot of medical problems. You'd never consider operating on the neck. Again, an EMG may be useful if you're considering surgery and you're wanting to go that direction. But otherwise, you're probably not going to do a lot with that information. The last but very important point is that it takes 3 to 4 weeks for axonal damage to show up on an EMG. Okay, so if you have a patient with some sort of even a stab wound, let's say to an individual nerve in the arm or leg, it takes 3 to 4 weeks for those changes to really show up fully on an EMG. Okay, so we have to wait. We don't do the test right away. Wait about a month, and then we can really give you some good information. Okay, the exception to that is Guillain-Barré, or an acute demyelinating condition. Okay, if there's conduction block, we can detect and pick up that information immediately. And so Guillain-Barré is probably our best example of a condition where we do an EMG from day one, ideally. Okay, and so next time we'll talk about peripheral neuropathy, which goes along very well with this topic.